subtroch fractures, and our panelists today are Dr. Spence Reed from Penn State, Dr. Susan Harding, Dr. Mitesh Shah from Hahnemann. So thank you all for being here. What I did, I got everybody's cases, so I think we'll start off with an easy case. I'll show you my first case, and then I didn't blind these cases. I didn't realize we were supposed to blind them, but we'll go. The later cases are a little bit more involved than the first simple case, so we'll just start off with basics. All right, so the first case is a 26-year-old male involved in a motor vehicle accident. I believe he was a unrestrained driver. It was this closed injury. His neurovascular intact. His compartments were soft, and this is just a simple, isolated injury. So I guess we'll just go down the line. So yeah, Mitesh, I guess you're in the OR. You're doing a case. You know, resident comes into the room. You know, shows you pulls up these X-rays on the computer. I mean, is there anything else you would ask the resident in terms of history? Any other patient factors you'd be concerned about, like how, you know, in terms of, you know, how he's doing, past medical history, medical comorbidities, anything like that? Does that play a role in decision making when you look at, you know, sort of a
sure,
bread and butter subtroch?
Yeah, I mean, absolutely. Obviously, with like high energy subtroch, you're obviously worried about like head injury, any bowel or, you know, organ injury or anything like that, any injury to the heart and lungs, that kind of thing. Basically, like ATLS trauma stuff. You obviously worry about co-committed injuries. Susan, anything on physical exam besides what we've given you here in terms of being closed and neurovascular intact?
Well, his body habitus is important in an injury, in many injuries, but especially in an injury like this, where you know you're going to be struggling a little bit with positioning issues and access, you know, starting points and stuff like that. You know, to just echo what Mitesh already said, I think I try to teach my guys how important it is to not be the trauma orthopedist that everybody thinks we are, which is that we're only focused on the bone injury and not thinking about the bigger global picture for these critically injured patients. So, you know, being aware of what's going on the other side of that screen is so critically important. And making sure, you know, people say, yeah, he's cleared, take him to the OR. And I've had times when I have told the trauma guys, this guy is not ready for a nail. They're like, no, do everything, he's fine. And if he's not fine, then that's up to you to decide as the operating surgeon. So you certainly go with their recommendations, their thoughts, their ideas, because they have the expertise. So I'm not saying that you overrule them constantly and cause friction, but you have to have an intelligent conversation with them and not just that knee-jerk, he's cleared. That I hate when residents come up to me and I say, how's this guy, is he ready for the OR? Yeah, he's cleared. They couldn't tell me what the results of the echo was. They couldn't tell me, you know, all these major factors that they need to know about in order to make an intelligent decision as a surgeon. So.
Yeah, I mean, it's simple things like, I mean, like you'd mentioned, you know, head injury. You know, would that preclude you from, like you mentioned, positioning the patient? You know, maybe some of us would do this case on a fracture table. Some of us would do it on a you know, in a lateral position, something like that. And I think, you know, part of those medical comorbidities would play a role in your decision-making in terms of not only how you treat this fracture, but simple things as, like you said, selecting the table or positioning of the patient.
And this is not going to be a short case, no matter how you do it. This is a challenging case. You're going to be on the table for a while. You're going to be reaming, so you have to take all of that into account in terms of his head, his chest, his hemodynamics.
Dr. Reed, any... So when the resident comes to the room and tells you, okay, you know, this is down the trauma bay, is there, in terms of initial treatment, right, in the trauma bay, what are your recommendations to the resident acutely? Not necessarily even like in the operating room, but before they even get to the operating room.
Well, I think it depends if you can, how quickly you can get them there. I mean, if it's going to be delayed, I'd put a traction pin in. If it's going to be parked in the unit for a while, I'm assuming they're probably going to do an abdominal CT scan, so I'd like them to scan through that femoral neck for me. Make sure that there's nothing hiding up there. You know, I'd want to get a lactate and see which direction it's going, and echo a lot of things that Susan said, you know, about making sure they're going to be able to tolerate what can sometimes turn out to be longer than you anticipated kind of case.
Yeah, absolutely. I think, you know, all these are eventually going to play a role in terms of how you're going to go about treating them. But just, did anyone hear that, understand the whole idea of, you know, these trauma patients, a lot of times they will have abdominal CT scans that will go through their femoral necks, and, you know, if this patient did have a femoral neck, which this one does not, but if it did, again, now you have 2 fractures you're dealing with, and then, you know, the conversation sort of rolls into, you know, 1 implant, 2 implants, things like that. So looking at that abdominal CT scan is absolutely critical. I mean, a lot of times you don't necessarily even have to ask for it. It's there for you. If you're more at a community center, then, you know, sometimes you may have to get some sort of advanced imaging to, you know, evaluate the femoral neck. But besides the CT of the pelvis or the abdomen of the pelvis, are there any other additional studies you guys would want before start to thinking about how you're going to treat this, Mitesh?
I mean, again, just echoing, making sure that we have some sort of visualization of the femoral neck to make sure you don't need to get anything in there. Maybe a lateral would be helpful just to get a better idea of how the fracture is sitting and how it's behaving.
Right.
But about it.
So
The other thing is just make sure you
there's
look at the
nothing down
knee.
the rest of the limb. But
right.
Yeah,
Yeah.
make sure you look at the knee, because this is probably a knee on the dashboard kind of event.
yeah.
And there could be just this good imaging.
Right, so I think, you know, all valid points. For this specific case, again, it's you know, an isolated injury. The rest of his lower extremity was intact. He didn't have any head or abdominal or thoracic injuries. All right, so now, you know, in terms of timing of the surgery, Susan, are you taking subtroch femur fractures, like you mentioned, if they're cleared, quote unquote cleared? Is this something you're doing sooner, later? Within, you know, 8 hours, 12 hours, 24 hours?
I don't think there's a hard and fast rule to follow. Every patient has to be assessed individually. Certainly following lactates and hemoglobins and stuff like that will give you a good idea as to where they're at in their resuscitation process. If this is truly an isolated injury, which is rare for this kind of an injury, and the patient is completely hemodynamically stable and well resuscitated, then I don't think there's any problem tackling this. Even in the middle of the night, if you're up for it and, you know, you have the team ready and so on, that doesn't really, you know, middle of the night issues, you know, there's certain fractures that it's not really indicated, but if this is an otherwise completely healthy guy and ready to go, I would do this right away. The chances of that being the case, though, with this kind of an injury pattern is unusual. So the flip side of the coin is that there's no problem, like, you know, putting them in traction or even in an X-fix if you think it's going to be a longer period of, you know, resuscitation and live to fight another day.
The interesting that's happened at our hospitals, because we're doing less and less at night, the ability to do hard cases at night is getting less and less. So it's like, you know, 5, 8, 10 years ago, this would have not been a big problem at 2 in the morning, and now it would be, for the system, much more challenging, which is sort of an interesting observation on things.
No, absolutely. I think, you know, same at our institution too. We're very rarely doing things in the middle of the night. I mean, at most we're washing out, maybe putting an X-fix on, but in terms of any type of definitive fixation, we're definitely not doing any of that in the middle of the night. You mentioned traction pins. Femoral traction pin or tibial traction pin?
I think that's dealer's choice. You know, a proximal tibial pin for a short term is fine. If it's going to be a longer period of time, you know, like maybe 10, 12 days or something like that, I'd probably go into the distal femur to let them move the knee a little bit.
Yeah, I agree. I mean, I think distal tibia, I mean, proximal tibia would probably be better just on in a shorter period of time, but then.
Yeah, I think it's dealer's choice. I think, you know, a couple of guys were very opinionated about this. They don't want any type of provisional fix in terms of skeletal traction out in the bone that's broken. Others are just like, you know, it doesn't matter, put the pin, you know, the distal femur is fine. It's not going to make too much of a difference. Are you using thick pins, skinny pins?
This gets attention 6'2", skinny wire,
Yep.
yeah.
You should
Yeah.
definitely convert to skinny
Yeah.
if you haven't already. There's a much lower incidence of pin tract infection. And,
And problems when they're removed.
right,
You know, they don't drain, they don't,
right.
All right, so
And you just have to make sure the knee's okay, obviously, that there's no major, well, first of all, we don't have a full tibia film there, so you'd want to make sure there's not a, you know, a tibial plateau or, you know, like a high Schatzker 6, something going on in the metaphysis or something like that. And you'd also want to make sure that you don't have a ligamentous instability, because you don't want to distract through that.
Just show of hands, how many of people in the room would advocate for doing this on a fracture table? Jack, why'd you on a fracture table? That's a good reason. How about the panelists? Supine, lateral, fracture table.
Do it supine on a flat top Jackson.
Supine,
Free-legged, right?
Free-legged.
Free-legged,
Free-legged.
yeah.
free-legged supine.
It's because I have
Free-legged.
residents to hold the leg
Learn
for me.
free-legged, it's so great.
I would
Dr.
say
Reed?
all three. It all depends. I'll do it anyway. If the patient's really, really large, I will probably do it lateral, free-legged, in lateral position on a radiolucent table. If the patient's relatively thin and the resident doesn't have much experience doing it on a fracture table, I'm doing it less and less on a fracture table, or semi-supine, free-legged. I think all three can work if you know how to do it. All three can work. But each one has its own little special treat for you.
Yeah. We did this on well, not this case, but we used to do them on a fracture table. I vowed never to do that again. It's the most miserable experience.
I just think
I wasn't that lucky with them.
yeah.
This
But
one
yeah,
might
I agree.
behave itself, though.
Free-legged is.
This is a little lower, so it might behave.
Yeah.
So I agree with what you said about, like, just know how to do, I mean, if you're a trauma guy, know how to do all the different approaches and the different positionings and stuff like that, because it'll always come in handy to be able to modify based on the individual's injuries and his associated injuries and so on. Polytrauma patients a lot of times can't tolerate a lateral position or a prone position, and so knowing how to do things supine, obviously important. If you're out in the community, I truly understand that you don't have the manpower necessary to do a free-legged technique. But it really does facilitate the reduction of this fracture tremendously. Because think about it, when you're on a fracture table, and we all know the deforming forces with the subtroch fracture, right? And that varus deformity especially, that post is right there, and especially if they have a big muscular thigh, the post is fighting you the entire time in your valiant efforts to reduce that varus deformity. And that's a big problem.
And the point that she made that isn't subtle is the fact that this proximal segment's relatively long. And so you could actually ream that proximal, we didn't even talk about implants yet, but you could ream the proximal segment and you could put a reduction tool into the proximal segment and use that to bring it to the distal segment. So there's a certain gift in this because you've got a relatively long proximal segment that includes a little bit of the diaphysis. So this is different than one further up where that doesn't exist. No, yeah, go ahead.
The tables, when you put the pelvic arch in the back table or on a table time, you can nail, I don't know if the world that does that, but you can nail the lateral traction. It's the hardest work you've done in the room. So you can get length of line limitation and nail it to the
Yeah, it's a good point. And the reason that lateral is so nice is because two things. One is you can flex up the distal segment to match the flexion of the proximal segment, and the starting hold becomes incredibly easy. So, I mean, it's one of those things where if you haven't done lateral, either way, either free-legged or on a fracture table, it's very daunting. It really sounds like it's very, like, this is going to a little bit freak me out. Then if you do it or get somebody to show you how to do it and you do a couple, you go, it's like, hey, this is actually pretty easy. This isn't nearly as scary as I thought it was, like a lot of things.
Anything but
Yeah.
anything but general anesthesia for this patient.
Yeah, you need skeletal paralysis, no
Right,
twitch paralysis. And that's
Right,
what
so
I look at the anesthesia, I'll say, I want no twitches for the next 2 hours.
Negative twitches.
Yeah, that's critical. I mean, that was the whole point of bringing that point up, is you really have to make sure that there's zero twitches. I mean, you want them to be.
Are they
Completely
completely
paralyzed.
unbelievable nonetheless? Are you like struggling and then you go, how many twitches does he have? And you just said that and they're like, just took 2, he's fine. No, he's not fine, we just talked about this, you know? Is that like universal experience,
that's
right?
universal experience.
Sorry if anybody's an anesthesiologist.
All right, Mitesh, in terms of treatment, are you a nailer? Are you a plater? Is this something that
Sure.
you know,
I mean, I think-
blade plate, or I mean, what are you
Yeah.
thinking?
I mean, I think this seems very amenable to a nail. I mean, I think that'd be my ideal option for this guy. Just less soft tissue stripping at that area if you can avoid it, and kind of get him all those, get him going. probably, ideally I go for a piriformis nail for this, again, just to send it right down the pike of the shaft. That way, just one less thing to help me avoid a varus deformity. Though sometimes that can be really tough in these guys.
Right. And any specific tools or reduction instruments you want in the room? You ask you ask your nurses preoperatively. They can bring it in for you before you get started.
Sure. I mean, it's probably a whole toolkit that we have now, but it's kind of grown over time. But basically, just everything from small to big. So for this, it's always like a stepwise progression in my reduction technique. So you pull on it first and see what you get from that. You push on it next, see if you can get anything from there. Then maybe small percutaneous options. So either like a joysticks, a diamond pin joystick kind of thing to get into the proximal and distal segments, or bone hooks, ball spike pushers, something that you can persuade it into the right area. Even something like
I forgot the shake.
the Harding shake, yeah. Or even like the reduction like finger that Dr. Reed was talking about too, inserting into the proximal segment to help find your distal segment and then continue on. I mean, honestly, you could go all the way up to opening, but I think like these guys were saying, I think this would probably be amenable to something more percutaneous right now.
All right, so that's a good leeway into the next slide. So it wasn't percutaneous. So we put them lateral, free-legged. We tried to do the Harding shake. The Harding shake didn't work this time. I tried. I gave it.
You didn't shake enough.
I gave it a shot. It didn't work. So we opened it. Looking at this critically, you're not going to hurt my feelings. What do you think, Susan?
Oh, well, I'm not going to hurt your feelings. So I think the Chance pin is a great idea. Obviously, you probably tried that first, right? Did you try that first?
Yeah. So
and you just weren't getting enough out of it, or something like that.
Right. So I mean, we tried to do it closed. We weren't happy with what we were seeing. And then the other thing is we mentioned earlier, and part of our objectives is how to gauge length, alignment, and rotation, right? Because a fracture like this, you're not necessarily going for anatomic reduction per se, but you want to make sure that their length, alignment, and rotation are somewhat. Well, not somewhat. You want to make sure they're acceptable. So yeah, I mean the incision was probably as big as that plate is. That Chance pin, maybe through another poke hole. What are your thoughts on putting those big clamps there?
I would probably try to use a point-to-point. I mean,
Right.
I don't know, it's style points, but once the clamp's off, no one knows what you did. That's the beauty of it. But in reality, the less soft tissue stripping, those lobster claw type clamps, I kind of threw them off my tray a long time ago because residents are the first to grab those things, right? Do you have one still?
Yeah, I grabbed them
Yeah,
back
you'll
on.
get rid of it soon enough. Don't worry. He's a youngin.
Dr. Reed, any preference on types of clamps? These big lobster claws or?
No. I mean, I use Weber clamps. Pointed reduction forceps. I mean, you want to that medial piece. You're depending on that to make callus at the end of the day,
Right.
And so you don't want to hurt that fragment's ability to make callus. And it's beautiful. It looks like you've got a beautiful reduction along the lateral side. And I agree. I mean, it's much more important to leave the OR with the femur appropriately aligned. It's easy to malrotate. It's easy to flex. It's easy to leave them with the proximal segment abducted. And if I'm struggling forever and ever, and it clearly isn't going to happen, I open it and I don't hang my head in shame. For the first couple of years of my practice, I would have hung my head in shame because my mentors would speak to me, but I killed all those voices in my head over the next decade.
I thought you were going to say you killed all those.
No, I killed all the voices in my head
They're
over the
all
next
gone now.
decade, and I realized that this is actually it looks great. It looks great.
I think you do what you got to do, right? You
Yeah.
follow the basic principles. You start with your most tried and true, reliable techniques and the basic principles of good soft tissue care. And then you get it done, right? If you have to make
yeah.
an incision, you make an incision. You
And
try
you-
to
and-
make
and
a minimally invasive incision.
And you don't have to put reverses around it and do all that.
Yeah,
You don't
yeah.
have to. I mean,
Oh, they're off the trays too.
what you see on an X-ray, it doesn't tell you the story of what actually happened in the operating room. And you can have the same X-ray with complete destruction inside, or an X-ray that is very elegantly done with minimal destruction. And so I'm assuming that's what I'm looking at here.
I love those little plates too. I found myself to be more aggressive about putting on like mini plates for either provisionary fixation or sometimes even leaving them on.
Right. So again, the principle of putting these plates on is similar to what the first session was about, right? I mean, you're holding provisional reduction. In this case, you're holding, length, alignment, and rotation. You have somewhat of a cortical read, with this type of fracture. I mean, you're not getting a read medially, but laterally we got a good read. So we were happy with that. We had that advantage, but, the cost of that advantage was, you had to make an incision. Whether that's good or bad, again, that's another, topic for discussion. I'm going to speed it up here a little bit because I got a few cases to go through. Real quick, so again, this is lateral, free-legged starting point. For this specific fracture, obviously starting points are critical, just as how the starting points for those proximal tibial fractures were critical. Mitesh mentioned earlier, you really want to, try and have your starting points a little bit more medial with subtrochanteric fractures. Our fellow came up with this like trochiformis starting point. I don't think I've even heard of the thing until recently, but what are you, subtrochs, are you using piriformis starting points or greater troch starting points? I guess I know what Susan's going to say.
Yeah, the right one. Piriformis.
You're not showing your age, are you?
Piriformis.
I think that's completely dealer's choice. I would, unfortunately, there are so few piriformis nails put in any longer in our hospital. I do it just to show the residents that it used to exist, but I don't think it really matters at the end.
Right, and that's the point actually I wanted to bring up is that we, in our hospital, we don't even have piriformis nails. So it's not even an option for us, unfortunately, as crazy as that sounds. So, we came up with this, sort of in-between starting point that kind of works.
So are you guys using trochanteric nails that are like cephalomedullary, like compression type nails? Like
they're not, no.
Nails that are made to create compression across like an intertrochanteric fracture?
No, we don't have those.
No, they're
So you're
greater
just
recon.
using a
They're recon.
trochanteric starting?
They're standard recon.
They're
nails,
recon
yeah.
nails with the trochanteric starting?
Yeah, they're like third generation nails.
Yeah.
Yeah, they're
So
not.
That's okay, because
Yeah.
the nail diameter is smaller at the top.
Correct.
And all that stuff that preserves bone in young people and stuff like that.
Yeah.
The only downside, okay, the theoretical downside, so everyone understands what we're talking about, is that if you drop a plumb line down the femur to facilitate the ease of achieving and maintaining reduction, that plumb line starts at the piriformis fossa and drops straight down. So any nail that starts in the trochanteric region, especially if it has a significant bend to it to accommodate that starting point, theoretically can like unassist you, like make it more complicated in getting that accuracy of your reduction. That's the thought. And everyone's concerned about the challenge of a piriformis starting point. But one good trick, just if you're looking to do that, is to use one of the curved awls that's cannulated from whatever system you're using. Most systems have them now, as a guide to place it into the right place. Don't try to use it as an awl to get your starting point, because I've always found that very difficult, but use it as like a place finder, and then direct your guide pin down through that curved awl. And that'll help you access the piriformis much more easily and keep your hand way over because you have control with that awl. That's a good little technique.
Yeah. And it's important to keep those starting points medial, right? Because as you come out more lateral, you tend to kick these things into varus. I think Bob Ostrom did that biomechanical study where, as you got more and more lateral with your starting points, they tend to kick them into varus a little bit more. So sort of the starting points we use now. Are you putting your guide pins all the way down? Or are you all the way down to the lesser, or are you putting them just a little bit? So certain nailing systems force you to put the pin all the way down to lesser, where some you only put it a little bit, and they have those channel reamers that you can sort of core your way down to where you need to be. Any preference on how far you're putting these pins down? Because you really want to create that corridor in your proximal segment so that when you finally put your nail down, you don't end up in a malreduction state.
Yeah, I find that sometimes I leave my pin a little bit short of the lesser. That way I have a little bit more control with the opening reamer. Get it right exactly in the direction trajectory that I want it to be, and then finish it off with that.
Okay. I'm just going to finish this case up.
Do you think you need to put screws up the neck in this case? Do you have to? I mean, this is a long proximal segment, totally intact lesser trochanter. I'm just saying that if someone was uncomfortable putting screws up the neck and they just use an oblique proximal locking screw in this, I think it would be fine, just as an aside. I would do this. This is what I would do, but in this long segment that's completely intact, particularly the lesser troch and everything else around it is intact, I think you could be totally safe with one and or two non-locking screws that don't go up into the femoral head in this particular subtroch fracture.
Yeah, I think this is, subtroch extends down into the shaft, so I think, I don't think it would be incorrect to use a standard antegrade femoral nail. I think in this case, the reason we used a recon nail is because the fracture came up a little bit more proximally. I feel a little bit more comfortable with fixation into the neck and head, so that, you're not, the theoretical risk of these things kicking into varus with a little bit more fixation proximally, I think is, it's just an insurance policy for me.
I think I actually have a case, I don't know if you're going to use it or
Yeah.
not,
Yeah.
of someone who did just that. They did a standard nail for a fracture that was not nearly this comminuted, but the level of the fracture was about at the level of the proximal extent there.
Yeah, and it just kicks
Remember,
into
the
it.
working length of your nail only goes from the most distal of your proximal interlocks, right, to the right. That's the working length. So it is a very short working length in that segment, theoretically, if you use a straight transverse screw.
So are you taking your plates off or leaving your plates on? Your provisional plates. Mitesh, you said you usually take them off. Is that correct?
I'll frequently take them off, but sometimes I'll leave them on for, I wonder if this might have happened for you, but the one thing that I hate is when you have it perfect and you take the plate off and it just tweaks a little bit.
Right, which is what happened here. Right.
Yeah, and you just kill yourself, and then you can never really fully get it back to that perfect thing again. You already kind of did the soft tissue, whatever, some mindful stripping just to put the plate on, so I don't think you're gaining anything by taking it off. I don't think you're losing too much by mixing like primary versus secondary bone healing on that outer cortex either. So I tend to leave them on if I can, but if I'm worried about the wound or something like that, like for a tibia, sometimes I'll take them off.
I think there's actually some theoretical benefit for leaving it on. There is rotational play in a tibial or in a nail. Have you ever just held a nail and just, it's not absolute stability, there's rotational play. That little plate is controlling rotation, and I don't know, I think there's some theoretical benefit to leave, probably downside from a theoretical infection standpoint, but there's a stability benefit too, I think, leaving it on.
I think you're absolutely right about the amount of rotational instability that persists after nailing a fracture that's, almost circumferentially comminuted like this. It's unbelievable. If any of you are doing non-unions, femoral non-unions, not with exchange nailing like we were always taught to do, but with plating around the prosthesis, which, I don't know, in my hands has turned out to be phenomenal outcomes for people that have struggled for such a long time with repeated nailings and stuff like that. What you get from that, besides, albeit maybe some compression, a little bit of compression if you do it aggressively in a compression mode, but what you get from that more than anything is rotational control. And I think a lot of these people have been doing this, inside there and just not able to heal that for whatever multitude of reasons they have, biology and everything else. But when you plate on top of that nail, how have your outcomes been with that? Are you guys doing that?
Yeah, the person, yeah.
Outstanding.
No, my preference would be to leave the plates on. The person who took this plate off got a beating when I looked at his x-rays at the end of the case. But I for all those reasons, I leave the plates on and have, knock on wood, I haven't had an issue yet.
Yeah, same thing with blocking screws. People do blocking pins, and that's okay, but blocking screws, I leave them in because the second you take a blocking screw out of like a metaphyseal region,
Right.
You just drift over it in the weeks to come.
Heartbreaking.
Yeah, unless it's like right underneath the skin or there's an open wound there or something, usually blocking screws, these provisional plates, usually I just leave them all in. All right, so let's just, I'm going to skip my case. We'll do, all right, we'll do Mitesh, your case next.
Sure.
So this is a 59-year-old female who had a mechanical fall with sudden right hip pain and inability to bear weight. Sounds like patient was pretty big, not the healthiest of people, is diabetic, has some heart disease, and high blood pressure. So similar, but not quite to the previous case. But I guess to note on this case, at least when I looked at it, what I saw is patient has a very large soft tissue envelope.
Yeah.
So I think that was one of the bigger concerns with this. Susan, you mentioned earlier body habitus in terms of the initial history and physical examination. When these bigger patients come in, that plays a role in terms of positioning and the table that you use. Is that part of your algorithm in terms of how you're treating these? If they're bigger, are you putting them lateral, whereas the skinnier people, you're putting them supine? Or how does the BMI play a role in terms of positioning of the patient?
Well, it definitely plays a role, and there's no question about that, because you're going to struggle more in your starting points and stuff like that. I think that either lateral or even just when I do my free-legged technique, it's kind of like a lazy lateral. It's kind of like halfway between lateral and supine. So you still get the advantages of being able to put them in a safer position, you know, quote unquote, for, you know, other injuries or a longer period of time. But the free-legged alone allows you to maneuver those fragments despite, you know, in light of the larger body habitus. I think it facilitates it. There, on the fracture table, you're very, very limited. As you get, you know, the bigger the person, the more problems you have with the fracture table working against you.
I'd just be curious to the panel, what kind of nail you might choose to use for this?
I think it's dealer's choice. I think you can go with, you know, you could go with either piriformis or lateral entry. I don't necessarily think you're, yeah.
How about what mode maybe? So either recon or cephalomedullary or just an antegrade nail. I mean,
this is a little higher, and I would probably lean more towards screws up the neck for this. Yeah.
Yeah.
Yeah, unfortunately, we don't even have that option. I mean, for us, it's always screws up into it's always a more of a trochanteric entry starting point. It's more, you know, of a recon construct where screws are going up into the head. We had a recent one where a fracture like this was underwent a retrograde nailing, and the whole proximal segment fell into varus, which I think is it's a similar case that I think we're going to show of yours, but that didn't work out so well. Dr. Reed, in terms of, are you looking for an anatomic reduction for this case, or are you going to treat it sort of, you know, if you've already decided you're going to nail it, are you looking for, you know, just length alignment rotation again? Are you want it to look like a sawbones?
No, I think length and alignment rotation are fine. You know, it's challenging, but I don't think you have to be anatomic per se. You don't have to have, you know, exactly lined up fragments perfectly, but length alignment rotation, that's going to make callus, unless you're going to violate it surgically.
Right.
But
that's a good lead-in.
That's a good lead-in.
So.
All right, so Mitesh, why did you do that?
Yeah, so this is it kind of went through my progression with her. So got her up on the table, pulled on it, and that posterior medial large segment was actually, it's almost like if you kind of log split the proximal segment. So it's there's an anterior half and a posterior clamshell kind of to the proximal femur. And no matter what I could, that posterior part was just drifting away from me the entire time. I just couldn't get what I felt to be a reasonable reduction in somebody that was pretty large and I'd like to get to weight bear pretty aggressively earlier. So, you know, tried to do it something percutaneously with some hooks. That still wasn't working, and then I eventually just made a incision, you know, about 6 centimeter incision, pulled it in, and just wrapped these cables around it, and cringed when I put up the X-rays to show Dr. Harding later. But
No.
But no,
It is beautiful.
I
It
think
looks
yeah,
great.
I think it looks very. I think it's a valid point. I think 10 years ago, if you showed this X-ray,
yeah,
right, you would be asked to leave the room, right? I mean, you'd be like laughed off the stage. I can tell you nowadays, I would probably do the same exact thing that you did.
I think
it looks great. How many people are putting cables around subtrocks now? All right, so more and more people.
Not
So I
all
think-
subtrocks.
No,
Yeah.
not all subtrocks, but 10, 15, how many ever years ago, we would never do this, right?
So
It would-
the
it would
ones
be,
that you really almost need to do it for is exactly what he
Right.
described, like when you have that hoagie roll, right? You know, you're like cutting it longitudinally. Those are extremely hard to hold, and the amount of soft tissue gap that interposes between those fragments can be substantial. That if you just let them fly, you have a really hard time healing that.
right, and there's studies now that support using cerclage cables for
Yeah, I
for
thought-
subtrochanteric fractures with, you know, good union rates and, you know.
The only shame.
I do have one comment to make, though. I don't honestly think that changes your ability to weight bear that. I think that may, in your mind, think
I
that,
think
but if
100%
you
it
put
makes
that
me
on an
feel better.
Instron
Yeah.
machine and doing it without the cables and tested it would probably be about the same.
I think you're probably right. I think just making getting a more a more better reduction overall. It just makes me feel better that this patient's going to heal, whether or not I had to make an open incision and use whatever tools to reduce it. So to me, you know, and I try to enforce this with the residents too, is that, you know, whatever you can do to get a better reduction is going to help you later on, and that's what most of our literature shows. The better your reduction, the better they're going to do. So.
The only shame comes when, like, one of my partners put, like, those invisible cables around,
yeah, the
because they
suture
thought
cables,
they'd
yeah.
get away with it and I wouldn't notice. Like, if you're trying to hide your cable, that's shameful.
What, fiber
Just
wire, big piece
wave
of
your
fiber
cable flag if you're gonna use it, you know? Because, yeah, because you can see the little crimp, you know? And I'm like, what's that? And he's like, oh, nothing, you know? Like, he was trying to hide the fact that he put a cable on, because he thought I'd be pissed off.
I also used a supplementary nail here. Would you guys have used maybe a recon nail instead, or?
Oh, you mean this is like a hip fracture nail?
This is
Yeah,
a
so like
fracture
hip fracture
nail,
nail.
yeah.
Again, it's subtroch fracture. I don't think there's literature to support either way.
Yeah.
I don't think it matters.
Yeah, I think for this one, how old was she? Was 56 or something?
She was 59, but she was
59.
like an older 59,
Yeah.
a little bit more concerned
I
about
think
bone
you have to
quality,
be careful
so.
maybe if you have a pure high transverse, like just above the lesser, or a reverse obliquity. Those, I would think that
Right.
this would be contraindicated almost, you know, that type of a proximal fixation, the proximal-most part, because you're actually literally pulling the fracture part when you know, with that compression mode. But I don't know, I mean, I guess you don't have to put any compression on it.
Yeah, and you lock it, make it a fixed angle.
Yeah, right.
All right. Anyone have any questions on this case? And then we'll just we'll move on to, we'll switch gears a little bit and show you different type of subtroch cases, a little not as straightforward. Any questions, comments? Saket?
Yeah, I just want to say one thing. I totally agree with, I think lateral positioning is way easier to get the starting point, way easier to get the reduction. I just worry about the rotation. I mean, at the end of the day, if I struggle, but I get a good result and I know intraoperatively I'm good with the rotation, I err on that side a little bit. I sometimes, if I'm lateral, I really am like, am I okay, not sure.
Well, I think you need to be able to know how to check rotation in the
Right.
lateral position. There's some very great, very good techniques that once you know how to do them, that you can leave. I mean, I get a perfect lateral of the knee, and I go up and I get a shot showing me the version of the femoral neck, and you can know exactly. It's 15 degrees off the C-arm. You can read the differences. So, I mean, I agree with you, but I think if you know how to do it, it's not quite as daunting.
How long do you work at reducing difficult subgrowth before you make any decision and do the direction?
That's a good question.
That's a
Okay,
very good
we'll
question.
go right down the lines. I guess Dr. Reed, and then we'll all answer.
Well, I mean, you sort of get an idea if it's moving in the right direction or not pretty quickly, but, you know, I don't know. I'd say 15, 20 minutes.
I think I'm going to give kind of a wimpy answer, but it truly depends on the patient. In an elderly patient, for example, where you know you have a kind of a complex fracture and you already want them off the table before you've even started, I almost go immediately to opening it. I have absolutely done that. Minimally invasive opening with appropriately placed clamps and just get on with the show. So if they're sick, to drop that lever happens much quicker than if they're healthy.
Yeah, I definitely would echo those 2 points. I mean, I think like you said, you kind of have an idea if what you're doing is working, and if it's not working, then you just move on to the next thing relatively quickly. So maybe 10, 15 minutes before you think.
Yeah,
it's
I'm
time to
probably
move
even
up.
sooner than that.
Yeah.
I mean, probably after 5 minutes, we have no problem opening subtrochs and exactly, getting to work, doing, clamps, plates, cables, whatever it is to get it reduced. So, I think as time goes on, I'm much quicker to pull that trigger. What about getting post-op CT scanograms to check for rotation? Is that something routinely you guys are getting? You just what Dr. Reed was saying. You get with the CT, you don't necessarily have to get perfect fluoroscopic laterals of the knee and work your way up and look at the anteversion of your femoral neck to gauge your rotation. CT scanograms, you can get that. You can actually get an actual number from the image. Any role for CT scanograms post-op for subtroch fractures?
Not routinely, not unless there's a concern.
Just if you have a real, like if they wake up and you're like, oh shoot,
Right.
like when you turn it,
Foot sideways.
So they wake up. How are you checking your rotation?
You should check it before they wake up. You should, if you're doing lateral positioning, you need to get them flat on the table and keep them under anesthesia until you make a decision that you're happy with your rotational alignment. And that should pretty much be a rule of thumb for, I think, any position. Like even if I'm doing mine supine or like lazy lateral or whatever, there's a lot of drapes in the way and you can't see the other limb and so forth and so on. So keep the patient asleep under anesthesia until you take the drapes down and confirm rotational alignment.
I think looking at the fracture reduction can sometimes be very misleading. Looking at cortical thicknesses and trying to match all that kind of stuff, I think that's very, very misleading.
Sure, please.
I've learned to open primarily every time. I didn't try it. I do you guys, I think my back table, I usually sit, plant it, I'm ready to speak of plant rotation, and plant drop it, stays great in the world, get what? But I wouldn't try necessarily, so I kind of put it out there, for things that less disease, and, but recognize that the goal of the spaces, it's not to be zero, there is a turn to yourself in the space. That's one thing. Second, so we're talking a lot about the different positioning that you can do this, and it's really relevant to conversation that Dr. talked about. But for those who may not be familiar with these discussions, many people think about the practice, right? So we get to the kind of spend on just a little bit like a pros and cons of the typical 2 or 3 positions, lateral, lazy lateral, supine, versus the back position, the pros and cons. From both a positioning perspective as well as the resources you can do. Because, for example, lazy lateral is not just in case you don't have the manpower, as well as the confidence on back to the element that can do it. It's very difficult right?
So yeah, to answer your first question, I think, the idea of opening these up, right off the bat, I think that's appropriate. I mean, I don't think there's anything wrong with that. I mean, you have to remember the goal of why you're there is to get a good reduction, right? I mean, that's paramount. Making incisions and what type of nail and everything, those are all secondary. If you don't have a good reduction, you don't have, what we've been talking about, length alignment, no matter what you do, it's all going to go downhill. So I think opening it up right away, if that's what you have to do, I don't think it's it's shameful in any way. It used to be a thing of pride. Oh, I wouldn't open up any subtrochanterics, but now, we open up a good fair share. So I mean, I think that's very reasonable. I don't know what the other panelists think.
Yeah, I mean, I agree. And,
Yeah,
and to the other question, okay, supine and a fracture table. It's easy to get length, it's easy to gauge your rotation, but it's really hard to control the flexion and the abduction and the external rotation of the proximal fragment. So if I was going to do it in a supine and a fracture table, one thing you can do is, because it's always flexed, you can take the distal part of the leg up to match what you know is the flexion of the proximal segment. Be quick to put a shank screw into the proximal segment to do all the things you have to do, internally rotate it, push it down, get it out of valgus, and then, open it. But like I said, every position has its own trick, and I think the reason I still teach my residents how to do it on supine on a fracture table is because they may need to do that when they're in their job at some future location. So I think it's nice to know how to do that, even though I don't do it as much as I used to.
All right. So is there I'm sorry, you had another question?
Control the rotation, wait for the second to line up, and then lock it after 30 minutes separately for locking the distance. If you overbeam and millimeter also more than meter, you can control the rotation like running.
Are you doing that with like, are you taking all the drapes down and sort of doing a second case?
After I walk, you see the proximal bone coming.
Right. So any Any comments on, I guess, he finishes he does the case, locks it proximally, closes the wound, breaks everything down, and then puts some supine, preps it, and then, plays with the rotation, make sure the pelvis and lower extremity line up, and then putting your distal locking screws in.
Yeah, I mean, I think that's a pretty clever way to do it, just to do it in a more familiar plane and like supine. I think you just have to be cautious that your fracture is stable in the other planes as far as, coronal and other, not just rotationally free.
You could lose length in that little transition, so I'd be concerned about, I like your technique. I'd just be a little concerned that you could lose length. Yeah.
Yeah.
A lot of these lateral entry recon type nails have a built-in version so that if your locking screws are going parallel to the joint on the lateral x-ray and that they're up the neck on the x-ray laterally of the hip, that you've put it in 10, 11 degrees of version so that the implant itself can give you a little help in some situations.
Yeah, it's a great trick though, and I think a lot of, doing orthopedic trauma is, just having a very deep bag of tricks. And while you might not use that trick every single time, when you're in a, kind of a desperation mode and things aren't going well, the more things that you've thought about, the more times you've discussed it with other surgeons and gotten their ideas and picked their brains and tried something new, the deeper your bag of trick becomes over the years, and that's the awesome part of trauma,
All right, so Dr. Dong, I'm sorry.
About 7 years ago, I started doing materials on an athlete. That is an excellent device to use for these typical substroke fractures. Is you put that way any place you really want it to be, and you just move the other leg out of it. You've got total control on that treatment. So I've almost abandoned doing it in a lateral position because of that. Very expensive device, clearly, but it's there anyhow. It's something to consider when you're trying to fix these difficult subjects.
All right, so I just want to make sure we get everybody's cases in, so we're just going to go really flat. We only have 10 minutes left, so again, open reduction is fine. Judicious use of cables, at least in our hands, I think free-legged is the way to go, and using these trochanteric nails helpful in morbidly obese people. All right, so next case is Dr. Reed. So this was a 48-year-old male, had a previous history of multiple trauma. He had multiple fractures, which we'll show you in a bit. Of note, he is a 1-pack per day smoker. He had a closed peritrochanteric proximal femur fracture, which I'll show you in a second. He did undergo an open reduction with nail, sort of what we've been talking about so far. And I guess it got to Dr. Reed at 6 months out because he had worsening pain with ambulation. And so I guess we're looking at the right hip. So Dr. Reed, you want to get us started, I guess? So
yeah, sure. So this guy came to us. He was referred for hardware removal, but you can see one of the screws has penetrated the head, and he's having pain with walking. He's 6 months out. I actually thought this was probably united, but I thought at this point that everything just needs to come out. He had normal infection markers, so our plan was just hardware removal. Would anybody do anything prior to that? It's okay, you can hurt my feelings. I'm not sensitive.
Yeah, I guess the concern is, what's his pain coming from? Is it from those screws inside of his hip joint? Is it coming from the fracture not healed? Is it coming from, is this malunion? Is that why he's having pain? So there's a whole bunch of reasons, but I think the initial approach, once you get all your labs and everything, and make sure nothing is infected, taking out the hardware, I think is a good starting point for sure.
I think I'd probably want to see a CT just to get a better idea, if I could, just at the fracture site. But sometimes it's hard with all that metal scatter anyway to really get a good idea of what's going on.
Would you get the CT now or after hardware removal?
I think I'd get it before, only because that way, I mean, unless you're gonna plan that, you know, you take out the nail and everything falls apart, you have something to put it back together with in the OR. It's the only thing I'd be worried about.
Say you took out the hardware and that scenario came up, like it's grossly ununited, it's a frank nonunion, and this is all you have because you went in with the idea of just taking your hardware out. Now, a symptomatic hardware removal case turns into a aseptic nonunion with subtro case.
Right.
What are you doing now? You're in the OR. I guess the better way of asking that question is, do you attack right away, or would you stop, maybe put them in traction, close them up, and then do your workup for a subtroch fracture? In other words, would you stage your definitive procedure, I guess is what I'm asking.
Yeah, I mean, I think personally I'd probably stage it just because for me I'd like to have all the equipment I'd want to have there and kind of think it through. But I think you could probably have a couple options.
I think this is an important example of like laying a lot of crepe and all the realms of possibilities with this guy before you even start. So I understand, like, you think it's healed, it looks like it's healed, but it's certainly something that, begs the possibility that it's not fully united once all of that hardware comes out. That hardware hides a wealth of sins. Mm-hmm. Even, obviously there's some literature that shows normal SED rate, CRP, white count. If you have those three are normal, then it's highly unlikely, almost 99% or something like that.
Yeah, but it's not zero. I mean,
it's not 100%. That's what I was just about to say, right? Yeah. But it's highly unlikely, but that doesn't mean zero. So there's still that possibility. So I think the place to lay that out to the guy is the first time you meet him. You say, look, we're going to go in and take out your hardware. And we'll see what that shows us when we do that. And we'll take some specimen of your bone and make sure that we don't grow anything in a culture. And if everything's solid, maybe that's all you need. But there's a good chance that you could need more. And what that more could be is a broad spectrum of possibilities depending on, what we find when we get in there. So just get ready for the long ride. Here we go. Like if this guy goes in just thinking he's going to have his hardware out and everything is going to be fine, he's going to be disappointed in a good percentage of the time, So just lay that out to them from the beginning so that they understand the gravity of the situation and stuff.
Hey, Matt.
Planning to fail. So what's the diagnosis here? Is this a union with symptomatic hardware? Fine, so take the hardware out. Is this a infected non-union with hardware? We'll figure that out. We'll figure out the OR. What's your plan? So CT can show you that is united or non-united. I agree, 100%. But then you go there with that whole plan back to A, B, and C. So you got to get it worked out. Maybe you want to aspirate the test. Maybe you want to try to aspirate something. You can infected, non-infected. And go in with that whole plan, not just say, hey, oh my gosh, well, they took the hardware out, now I'm in trouble.
So that's the. So moving along, you got cultures that grew at MSSE, IV vancomycin was started, and he continued with pain on weight bearing. He's off, for some reason it didn't come out right. He's off antibiotics, he's still having pain with weight bearing. So now you got your CT. So let me make sure this can. Dr. Reed is pretty fancy putting this up here. So let's see.
I was trying to get you some easy way to
so
get.
There you go. So there
sort of. It's sort of off to the side, but you can get the idea.
Oh.
It's okay.
Here, let me see if the other one will work. Sorry. It's a non-union.
It's a non-union, and he's developed sort of heterotopic bone about this. And really, there's two things at this point. There's not a lot of remaining real estate in the head. Although the head does not appear to be collapsing, there's a good-looking joint space, and there is the path through the proximal segment is not very clear. So he clearly needs to be stabilized. At this point, I thought he was no longer infected, but he had now a non-union with sort of complex geometry proximally. So I guess the question is, what do you do at this point with that? See if you can run that. Does that left one run?
Let me try it again.
Yeah, that's okay. Don't waste. That's okay.
Sorry, it's not coming up.
That's okay.
I apologize.
Yeah, I mean, looking at this, I think I'd probably lean towards maybe like a proximal femoral locking plate of some sort of fixed angle device proximally. Help try to, a proximal femoral locking plate over like a blade plate, maybe in my hands, just because you could direct the screws where you want them to go a little bit better. Though a blade plate can be a very powerful tool too, so.
So this, I'm going to show my institutional bias here, but would anyone in the room advocate for a proximal femoral replacement?
Yeah, how old is this guy?
Yeah, that's a good point.
50s,
48 or 50?
48. Oh, he's only 48, yeah.
Yeah, you're kind of a little
it's
young.
a little young for that. That's the
I
only
mean, it
reason.
might come to that.
So I
Yeah.
mean, it's a great question. You
Yeah.
know, the reason, no, it's a great question. The reason was I thought his joint space was normal, and, you know, even though his femoral head looked like it had been somewhat assaulted, it was still functioning, and, yeah. Oh, I mean, you know, and the guy had a previous infection there, too, which didn't warm my heart, and he's a 2-pack-a-day smoker, but anyway, yeah.
Just something to think about, but
Yeah.
so the CT, unfortunately, I apologize, didn't come through on one of the images, but it showed that basically the medullary canal was obliterated, so obviously the blade plate was used. It was done in a lateral position. Looks pretty good. Immediate post-op was stimulant Vanco beads were placed.
It's a little bit more valgus than I'd like, but I wanted to get the blade in the inferior part of the head, which was the only place, but there was, I think, some real bone left down there,
Yeah.
but it's in a little bit of valgus.
What are your thoughts on the use of an antibiotic nail for long bone infection? I mean, not just
Yeah.
necessarily this one, but for any type of diaphyseal infection.
I think that would have been another way, although I don't know if it would have given the stability that this would have given you. But,
Yeah.
I mean, certainly a good idea to deliver antibiotics.
How many people use antibiotic nails in their practice or are using them? Yeah, I think there's definitely. How are you? What an antibiotic nail to me may be different. What an antibiotic
Yeah, that's a
nail is
really
to you.
good question.
So what's an antibiotic nail to you, Mitesh?
So
Like,
I
how
mean,
do you make it, or how do you?
the-
You can't just get it off the shelf, right? You have
Yeah,
to do
no.
something. So what do you do?
a few different ways you can make it. I mean, you could take like the ball tip guide wire, wrap it around that. I know you can take like a chest tube, yeah, fill that and put the guide wire in, fill cement into that, and then you can cut the chest tube itself so that it comes apart, and you'll have the antibiotic cement around the rod, and then push that in. Obviously, you want to make it undersized and so it's easier to get out, and you're not really looking for absolute stability with that, but more an option to deliver antibiotics through the intramedullary canal.
So just as an aside, I mean, there's two kinds of antibiotic nails, structural and sort of antibiotic delivery, like you're talking about. The guide wire thing, I used that for a really long time, ran it down the inside of the chest tube and all that, and then it's, you know, and there's a little bead on the end, so you think the cement is being protected when you extract it. There's the rub. So I've actually, now I do it over a 6mm threaded rod from the Ilazarov set. And so the cement just binds all the way inside the threads, and I haven't had it delaminate on removal. Yes, I
left it
pulled out
behind.
the
Yeah, I had that
reaming
happen
rod,
once,
and there I
too.
have a cannulated canal of cement stuck in the canal. So yeah.
So you went on to heal, no infection. He's 4 centimeters short, and the plan is to do a lengthening procedure at a later date. I know we're out of time, but I don't want to cut Dr. Harding short on the case she gave us. But
I don't care, it's fine.
2 minutes. I'll pick one. Here, let me just go through the really. Here, that was a really. We'll go through real quick. All right, let's do 5
Oh,
minutes.
this
and then
one?
we'll-
This is gonna take forever.
Yeah, but I'm gonna fly right through it. So 54-year-old female fell while crossing the street. It's a question of whether a leg gave out on her. It was an isolated right lower extremity. Rheumatoid, morbid obesity, moderate obesity, or is that morbid obesity? Moderate, I guess. No history of diabetes, smoking, or bisphosphonate use. This is the fracture. So, was this patient on bisphosphonate, Susan?
No.
Or not? Was not. So, you know, sometimes when you see that lateral cortical beaking on the proximal segment, you start worrying about the bisphosphonate.
We thought she was by the
Yeah,
story and everything
that'd
else.
be my first question.
Yeah.
Once the X-ray percent, I'd bet that this was a bisphosphonate fracture.
So this is a low like you might even start to not even call this a subtrope almost, right? 5 centimeters, I don't know. It's right on the border, right? So it's a subtrope in its behavior.
So
But if you go to see what the first guy did,
So-
that looks like a really good job, right? This is what you were talking about, you know, like how high is, you know, how much can you get away with it? I don't know. I thought That
Yeah.
looked like a good job, right?
Yeah, I
I
think it
mean,
looks,
the guy that did it, I thought he did a good job.
so x-rays look good. You know, I don't think anyone would.
Obliquograms always look the worst, right?
Right.
Yeah.
Laterals look worse, looks fine. 7 weeks, now you're starting to see it maybe tip a little bit. You know, what we talked about a little bit earlier, is it going into a little bit of varus, maybe, maybe not. You just continue to wait.
Watching it, hoping, praying.
Not a lot of healing. Now
Oop.
you're about over a year, now it's falling into a little bit more varus, clearly not healed.
Screws are
Now
breaking.
screws are breaking. And then this was, is this where you got the patients? Is this?
Yeah, this was the first step. This lady's story is like years long. So I would not treat this like this now. This is earlier in my career, and you know, I mean, tried to do some compression plating. As you can see, I would plate around the nail. Absolutely, I like love that technique. I've had really good success with it, and a lot of people that are very happy after having a lot of other failures.
Right. This is what you would do.
Yeah.
Now, I guess.
Now, that's not her.
Right.
But that's what I would do now.
Right, and then
I
5
forgot
months.
to put that in there. Sorry.
Yeah, 5 months. It looked pretty good. It's doing well, and I guess around Christmas,
Boom.
she breaks.
That's when I thought she was healed. I had seen her like a week or two before that in the office, and I was like, "Have a great holiday." We were all like high-fiving and everything, because it was just really hard to see that it wasn't healed. And then she just broke.
All right. So at this point, I guess we'll take 2 minutes. What are the options? Mitesh, you want to sort of get us started?
Yeah, I mean, I think now you're probably looking at what you would do now, right? So you go in, you got to take out that hardware to make space because you have a broken plate. But I think you need something that will give you the stability for her to bear weight on, as well as some maybe compression. So I think that plating around a nail might be a good option for her now.
All right.
So I think at that point, I would actually go back and put the same plate on, because you're going to be there, and I would compress it with that articulating tension device.
I agree with you that I didn't have it well compressed on that first.
And I would make your working length a little longer, and I would get the screws out closer to the non-union to give yourself, you know, because that's going to dramatically increase your fatigue life.
Yeah.
And I think you can. This plate's famous for this. I mean, this is what this is famous for doing, unfortunately. But I think you can work with the biomechanics of the construct and make it work. Yeah.
Yeah, I agree.
And I'd probably bone graft it.
Oh, it was grafted.
Yeah.
Yeah.
All right. So we're 10:05.
Anyway, yeah, we went on to just re-nail her again, and after a pretty protracted course, she did
healed.
Go on to heal. But I guess that's just an exercise and don't give up.
Yeah.
That's good.
All right. Any questions for any of the panelists? Any comments? Any?
Oh, blocking screw at the top. Blocking screw at the top there. You can use blocking screws anywhere. Don't just think that they're purely tibial constructs.
Yes, sir.
This patient looks like has made a metabolic bone disease. Was any complete metabolic workup done?
Yeah.
For this patient? Number two, do you consider giving telecarotid to this patient? It seems to work sometimes. I had one patient similar to this. Before we ordered it to go, I started on telecarotid. I know it's very hard to get authorization for telecarotid. It worked after 6 or 7 months, so it started working, and it went on to do.
Yeah, she definitely has a metabolic bone process here. She's not on any bisphosphonates or anything, but the fracture is classic for, you know, a pathologic pattern. She has rheumatoid arthritis, and she's on steroids and other immunosuppressant type modalities, and she was managed by her rheumatologist for both optimizing her underlying disease as well as, you know, her metabolic bone issues.
The paper by Mark Brinker that outlines the endocrinologic metabolic workup for non-union is really worth reading. You know, they found that if you test non-union patients, about 85% of them are going to have something, and a lot of them, if you fix the something, most of it's vitamin D deficiency, parathyroid hormone, thyroid, they'll actually go on and heal in alone or with surgical treatment.
Can I ask the other, do we have a second or not? Sure. What workup, so when you're faced?
No, go ahead. I was saying, no, we don't have time, but go ahead.
Oh, I'm sorry. Oh, I was just going to ask, like, what you guys get when you do a workup for a non-union. Besides the imaging, what lab
You know,
work
the
you
thing
get?
is, Brinker's paper lists about like 50 things.
Yeah,
So it's really hard. I mean, I go with, you know, vitamin D level just because it's so prevalent,
right.
first and foremost, and then maybe a testosterone if it's a male. I mean, there's like, a couple of things. Thyroid is
Thyroid,
pretty
for sure,
common.
yeah.
But I don't get
You got to
like-
get parathyroid because primary, if you're going to treat a non-union, that it's the presentation for primary hyperparathyroidism some point in your career. That's how it's going to present as a non-union.
I'll post the paper on the website. How about that?
Yeah, good idea.
All right,
Okay.
it'll be on the OrthoClips website. So let's take a break. We'll